Okay, so let's do a little recap with some additions on our MDS Part 2 PowerPoint. Myelodysplastic syndromes are sometimes confusing to students, so I like to recap it and then add a little bit more information as we go forward. Just through some brief reminders, help categorization, help to kind of classify things with a little bit more clarity moving forward. Utilize those flow charts. They're going to be very, very helpful for you. I know we did myeloproliferative disorders and then myelodysplastic syndromes, and there are a couple of things like CMML that overlap. So let's talk a little bit about that again. Okay, so just to recap, a couple of points for the recap. What we're looking at in terms of MDS is our neoplastic pluripotent stem cell disorder. What we're going to see with that disorder is ineffective hematopoiesis, which is going to cause abnormalities in the bone marrow and the peripheral blood. So remember, we're going to have hypercellular bone marrow. We may have an increase in apoptosis of the cells. So even though we have a hypercellular bone marrow, we may see cytopenias in the circulating blood cells, which leads us to the point of characterized by one or more peripheral blood cytopenias. So it might be one line, it might be multiple, with prominent maturation abnormalities in the bone marrow. So what we're going to see is some morphology issues, some developmental issues, maybe cytoplasmic to nuclear to cytoplasmic asynchrony. We might see some megaloblastic tendencies, etc. So all of those things that can go wrong during developmental processes may happen because of that neoplastic pluripotent stem cell disorder. And again, this used to be referred to as a pre-leukemia because MDS can often progress into acute leukemia. A lot of patients die due to complications from those cytopenias before the MDS transforms into an acute leukemia. So a lot of times we see patients with myelodysplastic syndrome suffer with infections. Maybe they even pass away due to infections simply because they don't have enough white blood cells to help protect them from infection. And therefore, it's really unknown about of what percentage transforms into acute leukemia because sometimes people don't live long enough for it to transform or transition. But as a whole, we refer to this group as disorders as myelodysplastic disorders. But again, there are some areas of overlap with that myeloproliferative disorder because remember, we're going to have proliferation in the bone marrow, but cytopenias in the circulating blood. We're also going to recap our FAB classifications of myelodysplastic syndrome. And remember, we also have those World Health Organization. So again, we did talk a little bit about that clonal expansion of abnormal stem cells. And again, we have those divergent clones where they will then clone themselves, and then it becomes a series of generational divergent clones. So while they are not going to be developmentally the same, they will be clonally related. So they're going to be related to the same cell line. We are also going to have that ineffective hematopoiesis, but also premature destruction of abnormal cells. Because they are abnormal, they will not be sent out into circulation, and they will go through apoptosis prior to leaving the bone marrow. About 50% of those patients have unbalanced chromosomal abnormality at the time of diagnosis, so either trisomies or whole or partial deletions. And again, remember, the higher number of cytogenic abnormalities that you have, the poorer the prognosis. So I'm not going to say too much about this slide, but just as a reminder, primary myelodysplastic syndrome is usually idiopathic. There's a slight male predominance. It usually happens in a more mature demographic of people over the age of 50. And then, of course, as we age, our risk increases. We hardly ever see this primary myelodysplastic syndrome in children. And then we may have a secondary myelodysplastic syndrome, which is going to affect younger patients. It could be environmental mutagens, post-radiation therapy, or post-chemotherapy. So a lot of patients, again, we've talked about this, but a lot of patients who go through chemotherapy and radiation treatment for other cancers can then be more susceptible to developing myelodysplastic syndrome. Okay, so again, just a brief overview of some of our clinical findings. Patients are going to be suffering from fatigue and weakness due to anemia, and we call this refractory anemia because it's unresponsive to treatment. We might see infection due to that neutropenia, and it is probably the most common cause of death in myelodysplastic syndromes. And then we may have some hemorrhagic issues due to that thrombocytopenia. So all of those cell lines are going to affect the overall wellness and health of the patient. So anemia is going to be due to cytopenia of the red line. Infection is going to be due to that neutropenia or that cytopenia of the white line. And then the bleeding is going to be due to that cytopenia of the platelet line or the megakaryocytic line. Okay, so our laboratory findings in peripheral blood. Now this is, remember, just our overview. So if you have any questions, feel free to ask me. But what we're going to see in the peripheral blood are those cytopenias and dysplasia of one or more cell lines. Cytopenia meaning cytopenia of 2 cell lines in 30% of cases, and then pancytopenia in about 15% of cases. And that pancytopenia, again, remember, is just all of the cell lines are depleted or decreased. So RBCs are going to result in anemia, which is the most common cytopenia. We're going to have ovalocytes, oval macrocytes, really, dimorphic red blood cells. Remember, we might have some microcytic, hypochromic, and then we may have some oval macrocytes. We may see basophilic stippling, Howell-Jolly bodies, and in RBCs, and those are all things that are indicative of a myelodysplastic disorder. Remember, we have our ring sideroblasts, and that could be due to an environmental exposure, for example, like lead poisoning, perhaps. And we're going to see things like basophilic stippling. We may have some megaloblastic tendencies that are not due to B12 folate levels, but that's going to involve our DNA synthesis. So therefore, we may have those Howell-Jolly bodies, and then we may have those nucleated red blood cells, and it's an attempt to compensate, but also because we have that myelodysplastic anomaly, we may or may not have enough nuclear blood cells that can really compensate. So, or our reticulocytes or whatever it is, but for whatever reason, we may not have the capability to compensate appropriately. So instead of just seeing reticulocytes in the peripheral blood, we may see that nucleated red blood cell because, again, our body tries to compensate for its losses, for its deficits, and that could be a reason why we have those nucleated red blood cells in circulation. It can present like megaloblastic anemia, but again, those B12 and folate levels will be normal, and we may have a decreased reticulocyte count. Okay, so again, we're going to see neutropenia with our white blood cells, so a decrease in neutrophils or the neutrophilic line. We may have a left shift where we see metamyelocytes, myelocytes, and possibly even myeloid blasts, promyeloid blasts. We might see abnormal morphology with our neutrophils, so hypogranular or agranular neutrophils. And we may see that pseudo-Pelger-Hewitt anomaly, so that hyposegmented neutrophils, which is not due to a genetic inheritance, but rather an environmental exposure. Platelets, we may see qualitative and quantitative defects. So we may have a thrombocytopenia where we have a decreased platelet count, but then we may have morphological abnormalities in terms of qualitative features. So we may have giant platelets, we may have hypogranular platelets, and we may even have abnormal platelet adhesion and or aggregation patterns. And we're going to talk more about platelets and their function and all of their fun characteristics once we get to coag, but just know that there may be fewer than there should be and that they might not function appropriately, or maybe it'll be a combination of both thrombocytopenic and platelet function problems. Okay, so our bone marrow findings in MDS is going to be hypercellular, so we're going to have an overabundance of cellularity. It's hypercellular, but we are again going to see cytopenias in the peripheral blood due to that increased apoptosis and ineffective hematopoiesis. Now, the bone marrow biopsy is going to be performed typically to examine cellularity. So we're going to look at the bone marrow biopsy to see how many hematopoietic cells are present in that bone marrow. The bone marrow aspirate is performed to examine cellular morphology and do a differential. So biopsy is to examine cellularity, and bone marrow aspirates are performed to see what kind of cells there are and are they of normal developmental morphologies. So what we might see in that bone marrow is dyserythropoiesis. So most common things we're going to see is that nuclear cytoplasmic asynchrony, the same thing we see in megaloblastic anemia, but instead this is not due to a B12 folate deficiency. It is due to the myelodysplastic process, so dyserythropoiesis specifically. And then, of course, if we were to do a B12 folate chemistry test, those would come back normal. We might see abnormal nuclear shape, fragmentation, nuclear budding. We may see ringed sideroblasts due to that abnormal iron metabolism in red blood cells. And so remember, environmental things can affect our erythropoiesis or our hematopoiesis in general. And this is going to be a form of one of those refractory anemias when we talk more about it. I know we have talked about it in the previous lecture, but just as a reminder, ring sideroblast or refractory anemia with ring sideroblast is one of our myelodysplastic syndromes as well. Okay, so some other things that we might see in the bone marrow is going to be dysgranulopoiesis. That's really going to be abnormal granulocyte maturation. So we're going to see things like absent or abnormal primary granules in the promyelocytes and myelocytes. We may see hypogranulation of myelocytes and mature granulocytes. And again, we're going to see maybe some other anomalies that we kind of talked about before, where we may see some cellular division when it should not be happening in that maturation pool, etc. With regard to megakaryocytes, we are going to see in the bone marrow dysmegakaryopoiesis. This is where we're going to see decreased megakaryocytes. They may be normal or increased as well. We might see micro megakaryocytes in the bone marrow. We might see large mononuclear megakaryocytes or other abnormal nuclear formation. And there was a picture in our last lecture about myelodysplastic syndromes and myeloproliferative neoplasm. So if you can't remember what those look like, go ahead and take a look back at that. There may be absent granules or they may be large and abnormal. So anything that can go wrong might potentially be wrong. Okay, so continuing on, we did talk about our French American British classification and our World Health Organization classifications of MDF. Really, this is going to be based on the number of blasts, and that's the most important indication for survival and progression or transition into AML. So for myelodysplastic syndrome, we are going to have less than 30% blasts in the bone marrow for French American British classification, and then we will have less than 20% of blasts in the bone marrow for the World Health Organization classification. In terms of transition into AML, once we reach that 30% for the FAB classification, greater than 30% is going to be that line that we draw in the sand, so 30% or greater, I guess. At that point, we would classify what was once an MDS as an AML. And of course, again, that's for our FAB classification in the bone marrow. And then the same thing for the World Health Organization classification, but in this case, it's going to be 20% or greater. And that is the line we draw in the sand for that. Generally speaking, you need to know both classifications and the criteria that it needs to be classified as an AML versus an MDS. So I'm just presenting it to you in more simplified format here. Morphologically, there are two types in MDS and AML. So again, type 1, no granules. Type 2, we might see a few primary granules. So that's just kind of a brief review on the bone marrow findings with regard to classification and indication for survival as it's progressing into AML. So we want to know where to draw the line in the sand so we know when it has transitioned. Okay, so now diving back into that FAB classification, the least, least severe form of MDS is that refractory anemia. It's not responsive to any conventional forms of therapy. Anemia is going to be the main feature. We're going to have decreased reticulocytes. We may have, again, that dimorphic population with oval macrocytes, microcytic, hypochromic cells, red cells, and then white blood cells and platelets are going to be looking pretty much normal. At this point, we're going to have blasts in bone marrow of less than 5 to 10%, but we're still going to have that hypercellular bone marrow. And then we may see those megaloblastic RBC precursors, but they're not responsive to B12 or folate. So again, we have these megaloblastic features like we would normally see in B12 folate deficiency, but their B12 folate serum levels are normal and it's not responsive to traditional therapies. So the next type of myelodysplastic syndrome is going to be our refractory anemia with the presence of ringed sideroblasts. So we're going to be seeing into the bone marrow. We're going to use that Pearl's Prussian blue. And essentially what we have is those same characteristics as refractory anemia, but in this case we have 15% or more ringed sideroblasts in the bone marrow when we use that Pearl's Prussian blue to view our iron stores. So remember, that's more of an iron insertion or an iron deposition problem because of the iron metabolic inhibition due to some external environmental factor like lead poisoning, for example. And it isn't just lead poisoning, but that's one of the more common causes of it. The next classification or category under our FAB is going to be a refractory anemia with excess blasts. What we're going to see in RAEB is cytopenia in at least 2 cell lines. With regard to our peripheral blood, we're going to see hypogranular and hyposegmented neutrophils. So we're going to have that pseudo Pelger-Hewitt. We will see giant platelets or platelets with abnormal granularity. In the bone marrow, we're going to see hypercellular bone marrow with 5 to 20% blasts. And then all 3 lines, cell lines are going to exhibit abnormal development. And then patients with 5 to 10% blasts have a much better survival rate than those with 11 to 20%. And remember, although these are refractory conditions where they're not very responsive to treatment, the sooner we catch it and keep an eye on it, we can treat and at least know if this is going to, or looks like it's going to transition into an acute myelogenous leukemia. Okay, so on the most severe end of the spectrum, we have refractory anemia with excess blasts in transformation. And this is where we're going to see that transformation of a myelodysplastic syndrome turn into an acute leukemia. And again, just a reminder, this is the French-American British classification or categorization. What we're going to see with these patients is a very short survival time. It says in transformation, but it's really just approaching or breaching the summit of the mountain before you kind of have a snowball down the other side. Again, this is high risk of becoming acute leukemia because you're breaching that line in the sand. So 20 to 30% of blasts in the bone marrow. And once you hit that 30%, you are now considered an acute leukemia rather than a myelodysplastic syndrome. So it's a very fine line between myelodysplastic in transition and now acute leukemia. Okay, so the CMML we talked about in our last lecture, again, chronic myelomonocytic leukemia. It does have both features of myeloproliferation and myelodysplastic disorders. So monocytosis is going to be seen in the peripheral blood along with an elevated white blood cell count. Not always, but a lot oftentimes. We might see myelocytic cells that are prominent in the bone marrow. We're going to have anemia and sometimes splenomegaly and hepatomegaly. And remember, that's because of the proliferative aspect of this disease. They're going to have a high number of monocytes. And remember, those will go into circulation and then they will migrate out of the circulation and into the tissues. So you might even see, as the white blood cell count gets higher, and if it does transition into an acute leukemia, you're going to even see things like swelling in the gums and the mucous membranes simply because there are so many monocytes, they just migrate out and now they are an overabundance in the tissues. So that's also going to be apparent in terms of that splenomegaly and hepatomegaly. And in addition to that, because of their dysplastic features, there is a higher degree of apoptosis. Those cells are going to be plucked out. Some of them are going to be sequestered by the spleen and then broken down. And that's another reason why you might see that splenomegaly and hepatomegaly. So let's dive back in for a moment into the WHO classification. So of course the WHO classification has a more updated new diagnostic technique, plus in addition to that, they have some clinical and prognostic features. So one of the ways that there's a change is the number of blasts in bone marrow have been reduced to 30% to 20% in terms of that line in the sand between myelodysplastic syndromes and acute leukemias. With the same prognosis, but with a lower number of blasts. So there's a little bit less wiggle room. We are going to look at those categories with the World Health Organization and break it down into a few different areas. So we're going to have the RCUD, which is that refractory cytopenia with unilineage dysplasia. So refractory cytopenia with one line, and then we're going to have a refractory anemia with ringed sideroblasts. So that one is kind of the same as our FAB classification. We're going to have our refractory cytopenia with multilineage dysplasia. So in this case, multiple lines, cell lines are going to be reflecting that refractory cytopenia. And then refractory anemia with excess blasts. We're also going to have something called 5q deletion syndrome. And then we'll have also a myelodysplastic syndrome, unclassifiable. So we talked about a few variants of MDS before. I think one of them was like our juvenile, our JMML. But this is in addition to that, we're going to also see maybe some hypoplastic myelodysplastic syndromes. This is where we're going to have, rather than having a hypercellular bone marrow, we're going to have hypocellular bone marrow. The bone marrow biopsy is needed to differentiate from aplastic anemia or hypoplastic AML. So remember, there is some degree of fibrosis that can occur during MDS, and rather than having a higher percentage of fat and fewer hematopoietic cells within the bone marrow like you would see in aplastic anemia, now we just have kind of like a dried up landscape where you may get a dry tap. MDS with fibrosis, so moderate fibrosis of up to 50% in patients, and this is again associated with therapy related to MDS. So a patient who has MDS and who's seeking therapy for it, they may end up with fibrosis. Then we have unclassifiable MDS and then therapy-related MDS, again, secondary to chemotherapy, radiation. We see this form in younger patients who've gone through those therapies or have had radiation exposure. And these frequently present as refractory anemia with excess blasts or refractory anemia with excess blasts in transition or transformation. And this typically has a poor survival. Now, I think I mentioned in our last lecture, and I'm not sure if I did it as a recording or if it was in live class, but when we talk about diagnosis of these MDS, of myelodysplastic syndromes, oftentimes they say the most frequent or the most common type is going to be RAEB, and that's really kind of subjective, because one of the reasons why more new cases of myelodysplastic syndrome are diagnosed at this phase is because we start seeing circulating blasts in the peripheral blood. Most people, when they're feeling run down or they have anemia, they're not immediately going to run and have a bone marrow biopsy and say, oh, you have 20% blasts in your bone marrow. But once we start seeing circulating blasts, we know we have a problem, because we see the cells circulating as a reflection of what's happening in the bone marrow. So that's why we frequently diagnose it during the excess blast phase or even the excess blast in transformation, because those blasts that are in circulation really grab our attention and we say, hey, wait a minute, something is going on. Where before we might just see, like, maybe the guy has been having maybe he's been having some infections, and we see decreased white blood cell count. Well, we might think it's just because he's been fighting off this infection and he hasn't recovered yet. Or we might say, hey, these platelets look a little weird. Well, my point is, the thing that's really going to grab our attention is circulating blasts. Okay, so talking a little bit more about those variants of MDS, let's talk about 5q deletion syndrome. So what we're looking at here is a deletion of the long arm of chromosome 5. So it's going to be a deletion of 5q or 5q negative. Most people with this variant of MDS have a favorable prognosis and have a very low risk of transformation to AML, assuming that this is the only cytogenetic abnormality that they have. And in this particular variant of MDS, 70% of the cases are women. Now, in other variants or other types of MDS, we do have a higher prevalence of men over women, but this is the exception to the rule. So with regard, again, to cytogenetics, up to 50% of people with MDS or cases of MDS have some chromosome abnormalities. Usually it's deletions or extra chromosomes, but the more chromosomal abnormalities that you have, the worse your prognosis is. The exception to that is the 5q deletion on that long arm of chromosome 5. So just a quick review of prognoses. Median survival for all types of myelodysplastic syndromes is usually less than 2 years. Mortality rate is 60 to 70%. And then leukemic transformation is actually kind of variable, with 10 to 40% of those MDSs transforming into an acute leukemia. Transformation is less in refractory anemia and refractory anemia with ring sideroblasts. But once we get into those higher percentages of blasts, like we have in refractory anemia with excess blast, we then have a higher incidence of transformation into an acute leukemia. We are going to have a poor prognosis, including a higher number of blasts in the bone marrow, a higher number of cytopenic lines, higher number of cytogenetic abnormalities, and increased age and gender. So men have a poorer prognosis because most of the, I guess there's a higher prevalence of men with these myelodysplastic syndromes, And in the case where we actually have a higher prevalence of women with that 5q deletion, it's actually the only chromosomal abnormality that doesn't have a higher instance of transformation or poor prognosis. So I know we have briefly mentioned some therapeutic or treatment plans for patients with myelodysplastic syndromes, but we didn't really dive too much into it. Same thing when we talked about our non-malignant white blood cell anomalies. Some of these treatments and therapies are very similar. So for example, if we have um, a patient with anemia or a patient who's suffering from infections or from bleeding. And of course, these are going to be due to the various types of cytopenia that are present in that patient's disease state. So for example, we have a cytopenia of red cells, we're going to see anemia. If we have a cytopenia in the white cell and specifically neutropenia, we may be more susceptible to infections. And then if we have a decreased platelet count due to that cytopenic or thrombocytopenia, we may have a bleeding tendency. You might have only one of these cytopenias, or you may have all of them or any combination. The important thing is to provide supportive care for patients. So, for example, we would treat anemia with infusions of red blood cells as needed. Same thing with platelets for thrombocytopenia. And in the instance of infection, we would treat with antibiotics to kind of give our body a little help to overcome those infectious agents. So chemotherapy with AML type regimens for those with higher blast counts, but prior to transitioning to AML, because chemotherapy does not work as well for AML patients once you have transitioned. It becomes really refractory to treatment. There are a couple of newer treatments like growth factors and erythropoietin, and again, that falls under that supportive care. So if you have decreased cells or cytopenias across the board, we're just going to give our little bone marrow a little pep talk and say, hey, come on, you can do it. Here are some growth factors and some erythropoietin to kind of remind you what to do. And then bone marrow transplant for younger patients is really the only cure. There's really no cure outside of that. But there is a limit in terms of how successful bone marrow transplants can be. And typically, the younger demographic or the younger patients have a much better outcome with those bone marrow transplants than someone who is older. All right, so that is our recap on myelodysplastic syndromes. I hope this recap kind of simplified things a little bit. I know we went through a lot of information earlier in the week, and I know your heads are full to the brim, but hopefully this little recap will kind of break things down, simplify things, and get to the main point of things. It's not all inclusive, of course, but it is kind of just a simplification to help you organize your thoughts and your information more efficiently. So I hope you guys have a great week, and we are going to move on now to our lymphocytic cases.